All right, welcome back to the No Morning Show here on TTT. I am Natalie Legoran, and joining Raucus and I on set is Dr. Leon Lilas, urologist. The last time he was here, we spoke about the penis, but you know, about infections, hygiene, and of course about how long you're supposed to be having sex for. And I know many of you may have gotten uncomfortable for whatever reason, but I'm good over here. So hopefully you'll survive this segment of your body and you as well, because we'll be looking at the prostate cancer screening and just what we can do to safeguard ourselves as men, which is why Raucus is joining the conversation. Dr. Lilas, good morning to you and welcome.
Good morning once again, Natalie and Raucus.
Good morning, sir.
Thank you so much for being here with us.
Thank you for having me.
Can you remember where we left off? Because for me, I just remembered what stuck in my head was the 8 to 10 minutes, just because I know men and their egos, you know, and this idea that to be macho, they have to be having sex for an hour.
Well...
Sorry, I was just looking at Carrie, sorry.
Carrie.
Yeah.
Yeah, we got a lot of feedback from that. But it's not about, as in life, it's not about quantity, but quality, yes?
Yeah.
So yes, we can get past that. Now, today's topic is certainly a lot more serious, and we should put a lot more focus.
Yes.
Yeah.
Prostate cancer is rife. We are burdened by it. The Caribbean has been burdened by prostate cancer for over 30 years. There's estimated to be a 1 in 3, 1 in 4 chance for the Afro-Caribbean man to develop prostate cancer, and we do very badly at managing it, mainly because of misconceptions and lots of machismo and very silly stuff like that. Prostate cancer is second only to cardiovascular disease in cause of deaths, but it's certainly the #1 cancer in all cancers in terms of incidence and mortality in our setting. We hear a lot more about breast cancer and bowel cancer. It seems to have a more sexy flavor. Prostate cancer, well, these are older men that they live their life, but that's certainly not the case. But it's a significant burden, and there are lots of misconceptions about what is the prostate and what signs you have to wait on to get prostate cancer.
Well, let's start by clearing that up.
The signs, yeah. I mean, what is the prostate?
I mean, let's just establish the prostate is a very quiet gland. It's described as an accessory sex gland. It produces fluid which supports the spermatozoa in its transport through the genital tract. This meaning it supports sperm. When you ejaculate, you think that's sperm. 5% of that is sperm. The rest of that is mainly prostatic fluid that supports the sperm.
Okay.
And normally the prostate is very quiet in the background doing its job. But we get into problems with the prostate because of A, prostate enlargement, and B, prostate cancer. Prostate enlargement commonly gives you urinary symptoms. Prostate cancer can give you urinary symptoms, but in its early stages, absolutely silent. So I commonly hear, well, first of all, the common statement, well, I have prostate. All men have prostate. You're born with one, and it works quietly. Do you have a prostate problem? Well, if you're having urinary symptoms, you may have a prostate problem.
When you say urinary symptoms, what is
urinary problems. But the urinary problems can be grouped into two groups, what we call obstructive symptoms or storage symptoms. Obstructive symptoms, difficulty passing urine, straining passing urine, feeling that your bladder is incomplete. Irritative symptoms, having to go frequently, getting up more at night. Those can be signs of the enlarged bladder.
Okay.
But they're not necessarily signs that we wait for when we consider prostate cancer. Men say, well, I feel fine. You feel fine. In the early stages of prostate cancer, you will feel fine. The cancer generally occurs on what we call the peripheral zone of the prostate. And you won't have signs as you have enlargement. In fact, most men who have urinary symptoms, it's due to prostate enlargement, which is non-cancerous.
Right.
But if you're waiting on signs to go and check on prostate cancer, it can be too late. That's why we need to screen.
But what causes prostate cancer?
What causes? Well, there's no defined cause. We
Okay.
think genetics plays a significant role, so family history is very important. If you've got a first-order relative like your father, your brother, you certainly should be checking earlier than normal,
Right.
although all men should be checking. We think familial prostate cancer occurs in about 10%, but the rest are sporadic. We think the environment has a part to play. We're in an archipelago in the West Indies where we have the highest incidences in the world in some studies of prostate cancer. Why? On the western side of Africa, for example, their rates of prostate cancer much lower. So we think it's not just genetics, but the environment, the westernized environment. Because Afro-Caribbeans in New York, they had in the UK, Caribbean, very highest incidences worldwide. So, but most cases, there's no defined cause.
Okay, and is it curable? Is it something
Absolutely.
that you can...
It's absolutely 100%. Well, nothing's 100%, but if you detect prostate cancer very early, I counsel men every day, 95% cure rate. We're discussing vaccines here with efficacy rates of 90%, 85%. But early prostate cancer is eminently curable, but you've got to detect it early.
Right.
And if you're waiting until the iceberg hits the Titanic, it's not
late.
early.
That's too late.
You've got to say, well, it's a mile there, let's go checking.
So at what age do you recommend that men start checking?
Well, it's different.
Screening, sorry.
It depends on your risk factors. But as a broad brush statement for our setting, somewhere between 40 and 50 men should start screening. So for some men, it should be earlier, 40, 35. Strong family history, you can do it earlier. And what is screening for prostate cancer? We're trying to detect cancer at an asymptomatic stage where if we intervene, if we need to intervene, cure can be achieved. Screening is absolutely straightforward. 5-minute consultation, a digital rectal exam. Let's dispense with this immediately. The prostate examination that we do with the finger examination is the tip of the finger for about 30 seconds. Men have this concept that it's the fist up to your elbow for half an hour.
Wow.
Literally, it's the tip of your finger for 20 to 30 seconds than the average tool. And this can give us a lot of information way and beyond the other tests that we need to do. And that's done very simply in the office. The other part of the screening test is the blood test called PSA. PSA, simple blood test you can get in most private labs, most health centers, and you can do it. And most men, once we start screening, we advise you do it once per year. If there is a problem with the PSA or the digital rectal examination, then you should seek specialist attention. What you should not do is hold on to that. And that happens with patients and with GPs, unfortunately, and other specialists. We'll say, well, the PSA is abnormal. I did, but it's borderline. I did a rectal exam. It feels okay. I'll see you next year. No, that's not your decision to make. If there's something abnormal, let the specialist have a look at it, because we regularly diagnose people with normal PSA and normal rectal examinations. So you got to send them on to be assessed.
So how are you able to diagnose them if they have both normal?
Well, rarely both normal, so one or the other.
Right.
So, but the common scenario is, well, your PSA is slightly elevated, let's say 5. The general range given in the lab is 0 to 4, and your PSA may be 5. And you do a rectal examination, it feels normal because it's early. And then you say, well, it's borderline, I'll see you next year. That's inappropriate. There further testing that could be done on that prostate to give us more indications.
Tell us about the further testing.
Right. Well, the further testing includes ultrasound scan.
Okay.
But ultrasound scan is rather insensitive in early prostate cancer. So the main utility of an ultrasound scan is to direct biopsies where we would target the prostate. More and more we're seeing the advent of special MRI scans. Now, the MRI scan can give you a different dimension, but no scan is absolute. If we have clinical suspicion based on PSA, based on the feel of the prostate, based on the scan not quite being there, we then move on to a biopsy. And a biopsy is a straightforward outpatient procedure where we take a small needle and take very small samples of the prostate. Takes about 20, 30 minutes. We would have the results within a week.
So can you diagnose prostate cancer just based on the PSA score? Would you say if somebody has a score of 11 or 12 that you would see cancer is present?
No, you can't diagnose them, but you can get a good idea if they're likely to have prostate cancer. So just based on simple PSAs, if your PSA is over 4, between 4 and 10, you've got a 21% chance of prostate cancer. If your PSA goes over 10, somewhere between 50 and 60% will have prostate cancer. So it's sensitive, but it's not the only factor. We commonly see patients with, for example, prostatitis, inflammation of the prostate, which is very common in 30-year-olds and 40-year-olds, which would send the PSA up to 40. You know, my PSA is 40, I'm going to die. No, you're passing urine frequently, there's a bit of protein, this is a urine infection, we treat you with antibiotics, PSA comes down to 2. So, I mean, it's important to get the entire story, the history.
So an infection can cause the PSA numbers to go up?
Absolutely.
What kind of infection?
It's usually what we call a urinary tract infection, not usually a sexually transmitted infection. But as you get older, and older in this context, Raucus, it's not 90, but the prostate continues growing from your mid-20s.
Oh.
Unfortunately, we in
the
our
rest of us stops growing.
The rest of it stops growing. The penis stops growing. The testicle stops growing somewhere in your late teens, early 20s. But quietly inside there, the prostate continues growing and causing problems.
How far? I mean, where is your prostate located exactly? Like you keep saying, it's a fluid holder that translates to your sperm and adds to your sperm and comes out your penis.
Your prostate is, I mean, you can't feel it. We can feel it when we do a rectal exam. But the easiest way to think of it is just under your bladder and at the base of your penis, so deep inside your pelvis.
Okay. And you're able to reach it to feel it with just your fingertip, you're saying?
Yes, the average prostate, you can reach it with the tip of the finger, so it's very close to the anal verge, and we can actually feel the prostate. Very few organs we can actually feel in terms of making a diagnosis and workup. And with the prostate, simple pair of gloves, KY jelly, 20 seconds, and we're feeling the prostate. And we have certainly seen many patients, absolutely normal PSA. I don't like the examination. Well, my PSA is fine. No, but there's a nodule in the prostate, which I don't like. Let's recheck it. I'll see you in a month. I still find it.
So, Doc, you get to age 40, you recommend a screening unless there's some history or genetics involved. That screening starts at 40. But how often should you do that screening if the examination comes back normal?
Right. In general, once you start screening, it should be annually. There can be a debate when you stop it. Most people would stop somewhere around 70, 75. But most people, once we're screening, it's an annual event.
How much does it cost to do a screening?
Well, the cost of let's, for example, the PSA blood test, which is half of the screening, costs on average $200. But you can get a PSA quite for free in the health center.
Right.
You won't get it immediately, but you don't need it immediately. So there's little excuse not to be screened. You get your PSA, and of course, the rectal examination, it's literally for free. Cost of a doctor visit, and in the case of the health center, that's free as well.
Okay.
So you can be screened right now. What we do beyond that is a bit more complex and nuanced, because the treatment for one is not the treatment for all. As in appendicitis, you've got appendicitis, 99 surgeons will take off your appendix. You got prostate cancer, you may walk out the office and I say, fine, we're going to monitor you, surveillance, No, I think you should have radiation. No, I think you should have radical prostatectomy. So it's not one size fits all.
Right.
And that's
so you
very
spoke
important.
before that, you know, definitely curable once there's early detection. But what does that cure look like? What is it that you as a urologist does to ensure that, you know, this person is healthy again?
Well, I mean, how do we achieve cure? I mean, in very simplified terms, well, if you've got early prostate cancer, we can remove your prostate, that's called a radical prostatectomy, or we can radiate your prostate, killing all the cancer cells. After the major treatment, we then have to follow you up, usually again with a PSA, and we define a cancer cures no evidence of disease in 95% of patients some 10 to 15 years after the primary treatment.
Right.
So you know, most people would consider that cure.
What are some of the side effects of, let's say, removing your prostate?
Right. I mean, there are side effects to all treatments. Even if you go for a haircut, there's a side effect. It may not look good, it chops your hair off. There's side effects. Now, prostate cancer surgery has come a long way from 30 years ago, and we can get reliable figures now. But the things that we are concerned about with the operation or any treatment is preserving urinary control and, of course, men preserving erectile control. Again, the news is good. If you present early, I have the expectation of cancer cure, urinary control, and erectile control.
But how does that affect the fluid going to your penis, to add to the sperm if you don't have a prostate?
Of course, it does have a significant impact on fertility.
Yeah.
So if I contemplated removing your prostate, cancer surgery, your testicles where you make sperm is still intact. We don't touch that.
Right.
We can, bank your sperm before doing such a surgery, or if you didn't go down that pathway, we can still access sperm from your testicles to use for fertilization.
When is it, so you can access it as a doctor, or I can access it as a patient? When I'm finished, the surgery is done, we cure the cancer, we say, all right, 95%.
If you bank your sperm,
and
you would have your sperm.
Okay.
But I wouldn't advise you to go and take a needle going looking for sperm.
No, I mean your regular function. So if we have sex or whatever.
Let's separate it. Fertility and erectile function. Quite separate.
No, I'm talking about the end product of the erectile function.
The end product of erectile function.
The orgasm.
The orgasm.
Yeah.
Ejaculation.
Ejaculation.
You would still ejaculate. There are glands within the penis that produces fluid that allows you to ejaculate.
Right.
But the bulk of the ejaculation will have now gone, but the sensation
would still be
there. The orgasmic sensation would still be there, but you would have what's called a dry ejaculate. Now that, of course, happens in many cases, even if we don't operate on your prostate. Many of the prostate enlargement medication gives us what's called retrograde ejaculation. So you may see a reduction in your ejaculation, but you should not see a removal of the orgasmic sensation.
Right.
So it does impact fertility.
Right.
So we, of course, we counsel you and we decide where are you planning to have kids. So, but we aim to preserve, well, in cancer therapy, cure the cancer, preserve urinary function, and maintain erections. And if you present early, all of those goals are achievable. In the old days, and that's why cancer treatment got a bad name, people would present late. So the surgery was more radical, and they would clear nerves and vessels. And yes, you might be cured of the cancer, but you're unhappy, wetting yourself and no erections, and you know, so it's not a good idea. But it's now we expect going into these operations that we will preserve all of these, but only with early detection.
But if there's late detection, what happens?
Right. Late detection, we have to have strategies to deal with it, because unfortunately we deal with that daily. In our setting, many men still present late. I've seen recently, if the normal range PSA is 0 to 4, I've seen men with PSAs in the thousands. First PSA, well, 6,000. What? Now, by the time it got to 6,000, it's in your lymph nodes, it's in your bone marrow, it may be in your brain. Now, in the old days, your life expectancy from that start would be 6-9 months. But now, that has changed as well. Although we don't talk cure then, we talk control. But we can see reliable controls extending from 1.5 years, 6, 7, 8 years with good quality of life. And that's changing all the time, although it's very expensive. But of course, it's much easier and better for the patient, family, if you present earlier and we can cure you.
Right. So what are the treatment options for somebody who is diagnosed late and does have prostate cancer?
Right. The treatment options are largely based on what we call hormonal suppression. The testosterone made in your testicles stimulates prostate cancer. We either block the production of testosterone or block its interaction with the prostate. So it's hormonal treatment. In some cases, we can supplement hormonal treatment with chemotherapy. Chemotherapy was traditionally thought not to be useful in prostate cancer, but with the new chemotherapeutic agents, we found a different angle. More recently...
And that one would target the cancer cells?
It would target the cancer cells better with less side effects.
Okay.
But the big buzz in advanced prostate cancer are what we call the newer second-line hormonal treatments. Those are medication which targets the hormonal pathway at different steps. Very expensive. For example, one of the common drugs, 6,000-7,000 US a month. Yes. So.
So early detection it shall be.
Absolutely. If we can prevent that. But we're talking about hope and extending life. And if the difference between living 6 to 9 months and 9 years, and we have to look at that.
Let's talk about this late detection. If somebody is detected late and has prostate cancer, let's talk about the erectile dysfunction now, as well as the bladder control, the urinary control. What are those like?
Well, surprisingly, they seem to have little problems directly related to erectile control or bladder problems. Of course, you can still have urinary problems with the enlarged prostate, and prostate enlargement and cancer goes hand in hand. Would you become incontinent from advanced prostate cancer? Very rare. The problem with advanced prostate cancer is what we call metastatic disease, where it leaves the prostate and it goes elsewhere and it starts to attack the body. So the primary, the prostate, yes, you may get some urinary symptoms, but we can deal with that very effectively with medication or operations which last 45 minutes. What we can't deal with effectively is when the horse is bolted. And that would usually be the cause of the demise of the patient. That would impact on both their quality and quantity of life. But the urinary symptoms are garden variety. So you're going often, you have difficulty passing urine. We can fix that. Even in advanced cancer, we do palliative things. So the guy can't pass urine, and it's spread to his bones. But, I can do a 45-minute operation. He's passing urine. So we take that off the table while tackling the bigger picture.
So definitely early detection is critical.
Early is key here.
Yeah.
But that being said, the outlook for advanced disease is improving all the time. But you certainly would rather be in the early detection group.
Ruckus is already getting like, ooh.
Yeah, it's serious, right? So, when you start to get older, you start to realize that there are things that you're going to have to check. People don't think about it most times until it's too late. You say, when you're in pain is when you're going by the doctor. You don't think precautionary measures. You don't think, let me go and check and make sure that everything all right.
And I commonly tell men, I say, well, do you service your vehicle? They say, yeah, I service it.
I'm pretty bad at that too.
But you don't normally leave the engine hanging and the oil dropping to, I better go and check it.
I'm mechanic now.
No, but I say, so these checks you do with your GP and stuff, those are like servicing. Just, when last have you checked your cholesterol, your blood sugar, your blood pressure? Well, I feel good. So that's when you need to check.
Yeah.
Yeah, but
Yeah.
But that message is on a broader scope, and that has to go out.
Doc, let's talk about the psychological effects of being diagnosed with prostate cancer. How do patients cope?
Well, some not too well, and some stoically. Men generally are seen as the leaders of the family, and they think they need to be strong. But I mean, the diagnosis of prostate cancer and telling someone they've got cancer is always a bit of a traumatic event. So in my practice, I leave extra time for that. I leave extra time for their coming back with relatives and asking more relevant questions. It can be quite a load to handle. However, what we hope to do is have the answers to their questions right at hand. Yeah. So you present with early prostate cancer, say, listen, 95% sure we can cure this. You leave the office thinking 95%, fantastic, I can do this. But of course, in advanced prostate cancer, we can't honestly say that. Yeah. But we can give them the up-to-date data and say, look, the situation is changing. 10 years ago, you'd leave, you got 1-2 years and you're gone.
Remind us of the life expectancy for those who are diagnosed late.
Advanced prostate cancer without treatment, your life expectancy is around 9 months to 1 year.
But with treatment?
With treatment, easily, reliably, 4, 5, 6, 7 years versus months.
Right.
So quite significant. But of course, what we want to focus on is cure.
Right.
95%
So even with
cure.
the hormone therapy, with the suppression of the prostatic glands, it's still, your life expectancy is still limited.
Absolutely. What happens, initially you will respond 80%, but what happens afterwards, they become what's called hormone refractory. The cancer is always trying to evade, and it says, okay, you cut my hormones, I will develop alternate pathways. And this is where the second line drugs go and attack them in that alternative pathway.
This is some serious business, right?
It is very, very serious. I have a question though. Besides you said it would be difficult to pee, or you find yourself peeing frequently. Yes. Besides those two major symptoms, are there any other ways that you can suspect something is wrong?
In terms of prostate?
Yes,
prostate enlargement. That's enlargement.
Either one.
Right. No. So early prostate cancer, let's say there won't be any symptoms.
None at all.
Absolutely none.
Screening, early rectal examination.
Screening.
Right.
Screening.
With and PSA score.
Mm-hmm. Yep. PSA and rectal examination, you should screen. Once you get into that age group, family history, go. Do not wait for symptoms.
Right.
I reassure most men with urinary symptoms, it's not prostate cancer. Most men with urinary symptoms is prostate enlargement.
But can that lead to cancer?
Well, you just said that was a part of it, no?
No, they can be associated,
right?
But there's no causal relationship.
Okay.
So prostate enlargement does not lead to cancer. In fact, the part of the prostate, the so-called transition zone, which becomes enlarged in prostate enlargement, does not routinely go on to become cancerous. It's what we call the peripheral zone. Mm-hmm. But there can be an association. You can have an enlarged prostate with prostate cancer. So okay. And you, of course, because you presented because of enlargement symptoms, and I then stumble upon prostate cancer, that's fortuitous. So we would treat it.
Yeah.
So I would say to you, once you're getting urinary symptoms, address it.
Yeah.
But if you're of the right age, if you have the right family history, look at it long before you develop symptoms. Mm-hmm. And it could literally save your life.
Can family symptoms start with you? As in nobody else in your family had it and you're the first person?
You can be the index case. I mean, granted, our medical records and stuff all over the Caribbean. Well, my grandfather just died,
Yeah.
And they never knew why he died. Yeah. He had rip-roaring prostate cancer, but so you don't know if that's the family history. Right. But yes, it can start sporadically. So we say 9-10% has a definite family history. Mm-hmm. That means 90% can just happen sporadically. What can you do? You screen, or you try and prevent the prostate cancer.
How does one
prevent that.
Yeah.
How do we prevent it?
What can we change? We can't change our age or family history or ethnicity, but we can change our environment to an extent.
And diet.
Diet apparently has a key role to play in this, and this is where vegans come off smiling. Are you vegan?
No, I am definitely not. I love meat.
No. Cruciferous vegetables are supposedly protective. Broccoli, cauliflower, kale, lots of it. So we regularly advise on that plant-based diet. Meats, particularly red meats, unfortunately restricted. White meats, fine, properly prepared. That's on the list of good stuff.
All right, so white meats is like chicken breast, something.
Chicken breast, turkey, fish.
Fish, okay.
Those are good white meats.
Okay.
The red meats, unfortunately, are knocked in many things, including prostate cancer.
Where does pork fall? There always seem to be some...
they think that's the white meat, but just think of pork as bacon. And that's a red meat, and it falls as a red meat. But there we are. But that being said, I see vegans
who have prostate cancer,
who have prostate issues, prostate enlargement. So it's not one. It's
might
there,
be, yeah.
There are
it's not just any one
it's
thing.
not just one thing, but and of course, if you've got a family history, you want to mitigate your risk. You say, well, okay, but I'll just reduce my risk, and maybe I would get a less aggressive prostate cancer if I do get it. So it's all about risk mitigation,
right?
But and that's what we can do.
I think that's where we have to leave it.
Yeah, eat your
vegetables.
vegetables.
So much.
That's key.
Eat your
Most
vegetables.
importantly, get a screen to get that PSA score, get that rectal exam. If there is any family history or genetics, 35 years is the age that you might want to start getting that yearly test. If not, 40 years old. Get screened for $200. It sounds a lot better to me than treating with all of what I just heard Doc talk about.
Facts.
Yeah?
Facts are facts. Doctor, thank you so much for joining us this morning and for sharing.
Me. Next time we'll have a more jazzed up topic. We'll talk about...
I don't even know what we'll talk about next time.
What we'll talk about, Doc?
Doc,
let me hear, because I want to...
Premature ejaculation.
Well, you know what?
Oh, well, yes, that's actually...
Probably we'll have to invite you and Pottinger.
Oh, that'll
be
yes, we'll work on it for sure.
No
we'll
problem.
work on it.
Well, yeah,
it seems like we're going to have them as the in-house doctors, you know?
I mean, I'm mad at that. They have plenty of information.
Yes.
We've taken all the information we could get.
Yes.
Well, guys, on that note, I want to thank you guys for joining us inside the Now Morning Show this morning. On